Thank you. Appreciate you. Appreciate you. Okay, so most important thing is understanding what is optimal and what's dysfunctional. So we can't understand dysfunction until we understand what we are supposed to be like. Okay, so there's a lot of words on here, but we'll break it down. So posture basically refers to the alignment and the positioning of the body. So if you look over here, this is what our normal is looking like, right? So we have a little bit of lordosis here, a little bit of kyphosis, and then again, the lumbar spine has this little bit of lordotic curve. So when we see people in these crazy extreme postures, this is some of the things that we normally see. A little bit of lordosis here with the low back, or we have a lot of kyphosis, which is our guys who are super rounded forward, right? So looking a little bit different. So understanding this normal posture so we can understand some of this dysfunction. So also something I want to note is that normal varies from person to person, right? So, and also it depends on the sport that you play. So it's more understanding some of this so we can know why they are the way that they are. So we're looking for a functional posture, one that allows them to be pain-free and function optimally at their sport. So most efficient movement. So we're avoiding these like rigid ideas that these textbooks give us, because ultimately that's not how people function on the mound. That's not how people function in real life. And so we're also looking at leading into like our sports population. We're looking at our key performance indicators, which you'll hear us talk about a lot, our KPIs. So what do they need to do? What do they need to do? Why are they doing it? And how can we train them to be pain-free within that? So we're identifying any red flags, so persistent pain, any compensatory movement patterns, are we fatiguing under load? And we're using some of these sport-specific KPIs to structure our programs, right? So we always talk about things on a scale from performance to health, right? So let's say health is on this side, performance is on this side. As the year goes along, we're going more and more and more to performance. Now, obviously with the sport that we play, it's super unilateral. We're doing the same thing over and over and over again. So we're going more and more and more to performance. Maybe they're gaining a little bit more ER, maybe a little bit more laxity the more that they throw, depending on the person. Basically, our job and the way that I see it is that we need to bring them back to health a little bit and give them a little bit more balance. So that way when they go to play 162 games or how many ever games that they're playing, they have a little bit of leeway and a little bit of balance. So that's kind of like how I view our system, is between health and performance, and we're kind of bringing them back to this like neutral position. Anybody have any questions on that? Good? So it's the same thing. I think this last little part hits on too of like our KPIs and what matters the most, of like our sport demand matters. The way that we train a baseball player is going to be so different from the way that we train a football player, because they need compression. They need to be able to withstand being tackled, the head-on compression, whereas like baseball athlete doesn't need that. They need to be more rotational. They need to be able to move fast down the mound, and all of that matters. So like the way that you see, it's a little different with like quarterbacks with Jacoby, but the way that you see like a Drew Sample train versus the way that you see one of our big leaguers train is like a little bit different. So also time of year too. But okay, so let's jump into this. So as you can see on your paper and then also on here, we're going to be going over this first half of the eval form today, and then next time we'll go over the rest. So main things that I want to talk about today is we're going to go over what we're doing in the eval room, so going over background, going over what information we kind of need to collect, and then mostly today we're going to go over static posture and some of the things that we're looking at. So in the eval room, I know the coaches can go super fast where they're like going up, going down, ripping these things, and the coaches are looking. This is going to give you some ideas of the things that we're thinking about as they're going through this. So let's go first things first. Information intake. So I think this is one of the most important things, because basically what we're doing is we're painting a big picture. right? We're trying to find all this information. We're putting the puzzle pieces together so that we can see the big picture of what's going on. And in order to do that, we need to ask good questions. So we're getting background. And obviously this depends too on, are they a 14-year-old, are they a 10-year-old, or are they a big leaguer, whatever the case. So we're seeing sport, position, team that they play with, what affiliation were they working with, what is their current training schedule, where are they, are we in the beginning of the off season, are we in the middle of a high school season, where are we, so that we can kind of gauge volumes, what they're doing, so that we can start thinking about where we're going program wise. Those are some of like background, like, and I think the main thing too when we're in the eval room, and what I really want you guys to do when you start to sit in on more evals, is I want you to see how the coach makes the athlete and the parent comfortable in the room. Because I think that that's the main important part, right? A lot of people are traveling from really far to come here to get our expertise, and it can be very intimidating walking into the building with all that we have going on. So notice how the coach is taking time to make them comfortable, and then ultimately, you'll see this on the next slide, but we're building rapport and we're building trust. And that is the main thing that we're doing in this kind of intake section. So another main thing that I want to hit on is once you kind of got background and idea of what they do, we're going into, we already have them sign go through like a health history situation, but now we're kind of breaking that down. Do they have injuries? Do they have an injury history? What are the dates? So we're building out this timeline of like, okay, they had this sprained ankle when they were 10, and then they had, you know, this arm injury when they were 14. We're breaking down all of this timeline so that we're painting this picture. Some of this is, and it might seem, you know, nuanced to ask like a sprained ankle when they were 10, but all of that is super important. Like we've seen it with like manual therapy where we had somebody who sprained their ankle when they were 8, and then they worked through that, getting some of that tissue cleared up, and then all of a sudden their arm feels so much better. So all of the body is intertwined and connected, so some of these things are super important, even if they don't initially really seem like it. So, so limitations, are they in rehab, all these things. Training experience, what are they currently doing? So previous experience, because there's a difference between our biological age and then our training age. Do you guys know the difference between? What's the difference?
Biological age is age like in years, and your training age is like how long you've had experience.
Exactly. So like right now, for example, I'm working with a woman who's 62 years old, but her training experience is 2 months. Does that make sense? So that makes a difference. And then ultimately too, our main thing of the background and this sit down sessions is to figure out what our goals are. Where are they right now, and where do they want to be, and how can we help them get them to where they want to be? So that's also a huge part of that. So like I kind of hit on before, and we'll kind of breeze over this, but our professional etiquette of being present, being attentive, being locked into, you know, the conversation. We're giving them context of what we're doing as a coach. We're telling them, hey, this is what our experience is going to be like today. We're going to go over some stuff in the eval, and then we're going to head to the table. We're giving them a lineup so that they're super clear of what we're doing, because a lot of times people come here, they have no idea what we do. It is actually shocking how much people come in here and they have no idea what we do as a facility or how it works. So that's kind of our job to kind of show them and teach them. Speaking clearly, respectfully, I feel like that's pretty self-explanatory. And then obviously I said before, one of the biggest things that I think is building the trust and rapport, because they're coming here for our expertise and they're coming here to trust us, and this is one way that we show them that. So being observant, asking good questions. If something doesn't make sense, we're asking the questions to get a little bit deeper and deeper and deeper to kind of find the answers. So, and then follow through. And then one thing I kind of want to note on this is like your guys' role within this system. So as an intern, you're there to observe, soak it in, be present. Notice, I want you to notice what the coach is doing in the room so that that can make you, like your brain should be like, oh my gosh, he did this, this, and this. I'm curious why he did that. Like, let me write that down for later. Maybe not in the moment, but like, you know, when you get out of the eval room, so that you start thinking about these things of why we're doing what we're doing. Questions on that? Okay, let's jump into this main part. Lots of words, but we're gonna break it down. So, if you look at your little paper here, too. Actually, it doesn't really have it on this one, I don't think. I had to cut it a little short, so it doesn't have it on that one. But first things first that we're gonna kind of observe is our static posture. So we're gonna be looking at them at different angles, right? So first angle, posterior. We're gonna look at a lateral angle, and we're gonna look at an interior angle. So, all right, so let's break this down. Some of the things that we're looking for. Now, obviously in the eval room, this goes super quick, but these are some of the things. So, first thing I want to kind of give background to, so that you guys have context of what this is. This is the spine of the scap at the very top. This is the body. We have the inferior angle, and we have the medial border. So, when I refer to some of these things, this is what I'm talking about. Okay, so, all right, so as we break this down, our superior and inferior angles of the scap should align roughly with T2 and T7. So I feel like this pretty much aligns it pretty well. These are what we're looking for when they're just standing there, right? When we ask them just relax and we're standing there, we're noticing where their scap is in relation to their spine. And we're also looking for any big shifts, any crazy winging, any asymmetries from side to side, which we will see a lot of normally in this population. So if we go back here, you can kind of see like in this photo here, like the scap is kind of like hidden, but you notice that it's kind of depressed a little bit from side to side. And as we go, you'll notice like his trap is like super depressed. So that's giving us idea that his scap is very depressed. Our spine of our scap. So I added these photos in. So our spine of the scap, let's go back really quick. So, spine, this chart right here. It should sit at 30 degrees anterior angle from the frontal plane. I know that that sounds crazy. Might not make sense. But I feel like these pictures give a really good idea of where we should be. I know they're a little fuzzy on here. See how this is at this little bit of angle? Basically what this is doing is we think about the scap in relation to our rib cage, right? So if our scap is sitting properly on our rib cage, it allows better movement out and around, which is important for this population because a lot of what they do is they get out and around their rib cage when they go to follow through, when they go to throw. So if our scap is not sitting on our rib cage properly, which are people with like super flat T-spines, which we'll get into, or something like that, they have trouble moving their scaps out and around, which can honestly influence the way that they follow through. It can influence this. They can shorten and not actually get out in front. So all of that kind of influences what they're doing on the mount. So does that make sense, everybody? And that's also why we go 30 degrees in scap plane when we do our arm care. Does that make sense now? Because it's putting us in this good position rather than this retracted position during arm care. Do you guys have any questions about that? I know this is a lot of information, but okay, cool. So that's on there. We're also looking for depression and elevation. So I think that this pretty much outlines our different movements, right? So we have elevation here, depression, abduction, adduction, and then you can kind of see these different depressions and elevations. You will hear us say these words. This is what we're referring to. So our medial border, which is on the inside, should be about 3 inches away from the spine. So if we look back here, let's go all the way back. So if we're looking here, where's my little mouse? Okay, perfect. All right, 3 inches away. See where his inferior angle is and his medial border? It's a little far away, just a tad. We're kind of getting gist, but see how we can see where the medial border is in relation to the spine? See how we can tell? He's a little bit harder of a case in this particular like for the medial border, it's a little bit harder. So what you'll see us do, if we have trouble seeing it with our eyes, you'll see us use our hands to feel where the medial border is. Sometimes too, you'll have the right side is more retracted and the left side is more like this. You'll see some different weird wonky things. So here, medial border, and this kind of outlines some of this like winging off of the shoulder. So we're assessing for any pitching too close, rounding or winging, which is too far, protraction, retraction. So see how this is protraction, we're retracting here. This guy's scaps are whack. I don't know what's going on with his shoulders, but like this gives you an idea of some of the crazier things that we see. What does it mean exactly? What do you think? When you see somebody who has wing scaps, what does it make you think about? Yes. What else? Yeah, sort of. When you think of a wing scap, where does your mind go? Talk to me, people. Anyone?
Maybe they're really Latin on them.
Not necessarily, but maybe that's a contributing factor because they don't use what they're supposed to use. So when their scaps are super winged, my first thing that I think about is anterior tilt like this, which is true, which is what you did. But it's not necessarily like this, it's just like a little bit of this rounded forward. Remember in our beginning of our orientation when we talked about the difference between posterior tilt versus retraction? You guys remember that? So some of this and this winging is because they don't know how to properly posterior tilt. So they're not using their low trap at all. So they have a deficiency here. And then also maybe too, this person has a super flat T-spine, which I think is in the next couple slides. Super flat. So his scaps are not sitting on his rib cage properly. So maybe something that you'd see us give, a little upper back expansion, something in that realm, so that we give them a little bit of space this way, so that we try to teach their scap how to actually posterior tilt, and we give them a little bit of space for it to work with. Does that make sense? Okay. Inferior angle. So the inferior angle should sit flush. So this has the same thing to do with this inferior angle should sit flush. There shouldn't be any winging or kicking off. Where the heck is my flat T-spine? I don't know where it is right now, but also spine alignment. This is so hard to see in this context, but we have a ton of people we have way more people than you think who have scoliosis. This is an example of some weird stuff going on. This man had surgery for it, so that's why his spine reflects that. It's a little bit more straight, but if you look closely, and you'll see it on, when you look up this presentation on the drive, you'll see this a little bit better. It'll come out a little bit more clear, but it's all out of whack. And that influences how he is able to rotate on the mount. And important for like our coaching staff to know, because there's some positions he's just never gonna be able to get into. So no matter what, no matter how much we try to give him upper back expansion or things like that, we can try our best. But ultimately he has a structural difference, like he has a structural issue because he now has a rod in his back. And that's gonna influence how he throws. So, okay, let's go back really quick. So something also that I wanna kinda hit on is postural relationship. So we're talking about everything moving together, right? So we have the scap, the shoulder, the humerus position, and we're assessing all of these in relationship to each other. So we're gonna get into this too in the next couple slides, but assessing where the elbow sits relative to the torso. Is the elbow way behind? What does that mean for the scap? What does that mean for the humerus? What does this suggest? Are there muscular developments that are crazy different? Is our lat super dominant on our throwing side? Do we have a really dense like erectors and QL on their back? Like what are some things that we're looking at that they've built up that we can kind of start putting pieces together in this puzzle that we're trying to solve? So big picture thinking, We're always comparing left to right. We're seeing the difference between our throwing side and our non-throwing side, since that's the population we're working with. What is jumping out to you? What are some things that you're like, oh, that does not look right? And so, yeah. So, and I think that this last point is just basically saying that you're training your eyes to look at some of these things. So take videos if you need it, especially early on, so you can actually see what's going on. It's like, you know, when you're young and you're hitting off of a tee and you need to see what's going on, you video it to kind of slow everything down and break it down. So, obviously you guys are in more of a position of observation. The unfortunate part is, and some feedback that I've gotten is that you guys want more time, not necessarily this class, but the class before, of like, you guys want more time to like chat with the coaches. This is your time to do it when we're kind of slow, because it's not going to be slow. So like, if you sat in an eval, and now that we've gone over some of this stuff, like, start asking the coaches questions. Now obviously have some feel with it. If they're busy, like, you know, let's be respectful of that, but start asking questions of things that you saw. Why did you see this? Why is this? Start asking those questions now while we have a little bit of time to kind of do that. So, okay, that was posterior. That's just what we're seeing from the back. And remember, all of this happens in like seconds. So, anterior, we're looking at our head and our neck. So, is our head over top of our body, of our centered between our shoulders? We're looking at our clavicles. So our clavicles and our scaps mirror each other. So if our scap is super depressed, then our clavicle is probably also going to be a little bit more depressed. So we want them to have a slight upward angle. Notice in this photo, this guy has some asymmetries. What do you see? Right, the right side's lower than the left. A little bit more depressed. What else? Let's see. So we're going, any muscle imbalances for their rib positioning. In his rib positioning in this picture, we don't really notice anything, but you'll see in some of the guys that are like this, super rich, you'll see their rib flare. Like me right now, you can see my rib flare, like if I were doing this eval. Where is his nipple line? Does he have a right lower nipple in line with his lower clavicle, in line with his lower depressed scap position? Is this all lining up? Sternum line, so should be pointing straight forward. What do you notice about him? Yeah, he's like a little bit angled this way. So his sternum line is like a little bit to the side. Arm and shoulder position, and this is like, you can kind of see this, but we'll get into this when we view them from the side. But we're assessing the acromion relative to the elbow. So we're assessing this relative to where the elbow is. We'll get a better picture from the side, but we're starting to notice some of these things. Like, yes, you can tell his right arm is back behind, which is typical of what? What did you guys learn with Andrew? A left AIC patterning, this little bit of rotation back. All right, what else we got here? So we're looking at the humerus, the forearm, and the hand. Where are they all sitting next to each other? Are they super internally rotated this way? Is our hand facing behind? Are we rotated fully like this? Are our hands to the side? Are our hands like this? What is everything doing in relationship to each other? Trunk and rib cage. So obviously we already said check for any sort of rib flare. We're looking at the pelvis as well. We're looking for any crazy differences from side to side. It gives us an idea of which way the pelvis is kind of rotated as they stand, especially if they're sitting like this. It gives us an idea of which one's kind of hiked, which one's not. Where are they sitting in that? Is he anteriorly tilted? Is he posteriorly tilted? Is he swayed back? And then as we go through this, we're looking at pelvis, knees, and feet. So we're checking ASIS, which is like this front part of your pelvis. Our knees stacked underneath the hips, our feet evenly spaced out. So as I go through this, so I'm gonna kind of give you what I do and how I systemize it, because I think you have to build your own system when you're doing this eval process. I always look from the ground up. So if I have an athlete standing in front of me, I'm gonna look at what their feet are doing, their knees, hips. I'm gonna go all the way up the chain because that's how my brain functions. I go through my checklist like that from the ground up. And then as they spin, same thing. If they're spinning and their feet are like this, or their feet are like this, it gives me context to the big view. So this side view, and this is kind of what I was talking about where our acromion is sitting in relative to our elbow and our hand positioning. This is a good positioning. What we don't want to see and what we do see a lot is this, where our elbow sits way behind. What does that do to the scap position? Talk to me. Talk to me. What does that do? Our elbows go way behind. What does that do to our scap? Yeah. Wait. Is that what you said? Okay. I was like, couldn't hear. Exactly. So we're looking for ears stacked over the shoulders. We're looking for where our hands are, where our elbows are. Let's see what else. We got thoracic spine like we talked about earlier. We're looking for that slight kyphosis. If we don't see it, we're noting that they're super flat T-spine, where our scaps may sit a little bit off. Yep, and then this is basically everything we kind of already hit on before. But we're taking our view, we're doing, and this is the same thing that we've talked about with coaching, right? We're always zooming out, looking at the big picture, and then zooming in. So we zoom out, we look at the whole, and then we look from the whole this way. And then maybe we look from the front, like we have them turned to the front. And then maybe we're specifically looking at clavicles, nipple line, and then maybe we're turning them around looking at scaps. So we're zooming in, seeing big picture, we're zooming out, looking big picture, and then zooming in, looking at some of those smaller differences. Here's I knew it was in here. Okay, so spine and rib cage. So look how flat that is. That is an example. Does everybody understand what that looks like or what that means? Especially now that we have a picture. Yes or no? Are you guys with me? Yeah, okay. So notice how this is super flat. This has this little bit of kyphosis. These are kind of the two buckets that we put people in. But yeah, this just gives you a picture of what some of this looks like. Okay, so as we start getting into our flexion and our abduction, it's important to notice or to know the scapulohumeral rhythm and what does it mean and how do they work together, because they do work together. And you guys can kind of break this down too on your own if it flies over your head. But our first 30 degrees of shoulder elevation, is initiated by supraspinatus and deltoid. That's why I really want you guys to take a look at the other PowerPoint that's in the drive, because this gives you actual photos of different muscles and what they do and what does the infraspinatus do, what does the subscap do, all of these things, so that you have context to some of this stuff. So after that, every movement is a 2-to-1 ratio. So 2 degrees of humeral motion for every 1 degree of scapular upward rotation. So as we go up, it's important to note that relationship. And this kind of shows that. What we're watching for, and we'll get into this in the next slides when we're talking about abduction. What we're looking for, does everything move together smoothly? Is it early? Is there a delay? Is it hitchy? Is there smooth control? Or is there crashing? Do we notice any soft tissue restriction? Do we have to assist them into upward rotation? Do they have control over it? All of these things that we're kind of looking for. So, let's look. So let's get into flexion. Alright, I'll play it one more time. And we'll kind of go over this too. But this is just an example of what that looks like. So, arm and shoulder position. Do the arms finish in line or past the ears? Okay? And when they do this, are they compensating? Are they compensating with their rib cage? Even watching from this angle, I only put one angle, which preferably we'd like to see it from all the angles, but even from here, what do you notice when he goes up overhead? What are some compensations at the top? What does he do at the very top? What do we think? Give me an idea. There's no right or wrong. We're just talking about it. What do we think? Do we want to see it again? At the very top, does anybody want to give me an idea before I share? Yes. At the very top, he goes like this, and then he pushes his chest out. What does that tell us? Come on now.
I don't want to answer every time. Like I know that.
Well, then answer once.
Lumbar extension.
Right, could be. Rib flare. Maybe limited in shoulder flexion, which is our main thing. Is one arm higher than the other? Does our throwing arm struggle to get up overhead, but our other one is smooth? We're looking for any of these, right? Scapular mechanics, right? So we're looking at inferior medial border. We're looking, does it rotate without compensation? We're looking at all these things, and this can be a resource for you guys to kind of look back on as you're thinking about some of these things. So we're also looking forward head posture. That's a compensation at the top where he pushes his head through, our ribs flared, yeah, all of that stuff. So global picture. Can they achieve full range of motion without compensation? Yes or no? And then we're writing down those notes as a coach. We're kind of just painting that picture. Is the motion controlled? Is it pain-free? And is it symmetrical from side to side? I think that those are some of our main things with them. Right? Be shifted like this. Could be shifted. Could be a rib cage issue. This is, and that's exactly what we're looking for. We're looking to find out those things so that when we go to paint his picture in his eval, maybe he's limited on one side more than the other. Maybe when he goes to touch his toes, he has a rib hump, so we know that his rib cage is shifted. So it could be a multitude of things, but that's what we're doing, and that's where we need to get to, where we're looking, okay, he's like this on this side, and I can't remember if he's a righty or a lefty, but he's like, even notice too, notice this is more tilted than this side. So it all relates to each other. What else? But yes, main things are motion. Is the motion controlled? Is it pain-free? Because sometimes it's not pain-free. And then maybe as a coach, we're assisting them into upward rotation, or we're limiting their elevation. Does that make sense to everybody? Because sometimes what happens is if they elevate as they go up overhead, their humerus hits the top of this AC joint and pinches. So we can kind of decipher what their issues are depending on if we go to support them and we help them into upward rotation and we limit the amount of elevation and they have no pain, then we know that all that they have to do is create good upward rotation and good movement. And that's when you'll see this one, that's when you'll see our serratus, that's when you see our wall slide, all of those things, so that they can start to gain control of that movement rather than just elevating as soon as they go up. And they're actually moving their scap and controlling their scap. Make sense? Okay, cool. Shoulder abduction. And obviously, in the room, you'll see the coach take different angles on all of these. I only put one video in here, but same thing. So our arms level and symmetrical. Is the humerus centered? Elbows drift or bow out as they go up overhead. Like, do they go straight up like this, or do they go like this? What does this mean if their elbows are bent? What do you think? What do you think? Think about it. Brains. Not biceps, but some things tight. Lats. Maybe they don't have true shoulder flexion and their lats are super dense. When I take my arms up overhead, my arms bend because I can't get up overhead without my ribs flaring. Does that make sense? Okay, so same thing. We're looking for smooth upper rotation without shrugging, avoid winging, upper trap, core rhythm, all of these things that we kind of talked about before. What are some things that you noticed about this? What do scaps do first? I wish I had a slow video of this. Go back. Alright, what does the scap just do first?
Retract.
Yeah. His scaps retract and then he goes back up. Why does he do that? Why do you think? Why do you think he does that?
I think first it's just something that's taught probably.
I think that that's really fair. Also, too, look at where he starts. He starts in this like super protracted position, and if he goes to throw, he needs to get back into like this good position before he can get his arm into a good spot. So I think it goes back to the it's taught. People are taught to like, and you can speak more on pitching stuff, but like people are taught to do this like scap. What is it called? Yeah, scap loading. So they aggressively think they have to like pinch over to get where they need to be. And that takes so much more time to retract and then go back up. Or you'll see them go down to go back up. That is dysfunction. We want them to start at a good position and then for them to upwardly rotate and then come back down. Not retract and then go back up. So those are some of the things that we're looking for. Any questions on that? So external rotation at the side. So what are some common things that do you think that we see with this? That we kind of already hit on a little bit with some other stuff. With shoulder external rotation. Feel free, anyone, chat. I mean, it's on here, but what are some dysfunction things that you think people might do? Common mistakes. Go ahead, anybody. You can speak up. Yeah, retract. Rib flare, all of that. That's common that we're gonna see. Especially if you'll see this, like rib flare retracted position, and a lot of our college athletes, because that's the way that they train in college. They back squat, they do a lot of heavy loading, and so they come in and they see us and they're like this. What's the issue with this position? What's the issue with this like retracted position? Give me something. What's the issue with that when you're throwing? Say it.
You said when you're swinging retracted,
Yeah, when you're retracted.
push forward,
Right, you're
On the
pushed
toes.
forward. What does that do when you go to throw?
jump.
You could jump this way. Does that make sense? You got confusion. You got confusion eyes. So think about when you're on the mound and you're stuck like this. Your momentum is going this way, right? If you go to throw, a lot of guys have trouble sitting and being in this position because they're stuck like this. Just like Andrew talked about before, it's like a tube of toothpaste, right? If I squeeze this back here, my tube of toothpaste goes this way, so my airflow goes this way. It's the same thing. If I squeeze the tube of toothpaste this way, my airflow goes back there. We want to create balance. If we're stuck like this and we go to throw like that, jumping off the mound this way, maybe we're stuck out here, maybe we cut into the ground because we can't get our arm in the right position at the right time. Does that make sense? And also too, think about if they're stuck like this and then they go to throw, they might have a harder time getting their scap out and around because their scap is sitting in this like stuck back position. And I can probably guarantee that they were back squatting instead of actually working on how to properly control this movement, which can lead to injuries because they don't know how to properly control it. So, but that leads to the point of when we're here, we're just looking at any crazy asymmetries. We're looking, do they actually use their infraspinatus, or do they use their rhomboids to retract? Do they actually know what they're supposed to be doing or not? And this kind of lays it all out. But like, does the humerus stay stable? Is the motion smooth? Is there any drifting or elevation traps, like you said? Is there any crazy density, asymmetries, anything like that? And then what we're thinking about is the motion controlled, pain-free? And what does this reveal about their actual rotator cuff function? Do they actually know what they're doing? Do they have capability to do it? Or do they just are they taught something else, like the retracting? But yeah, this is an example of like what this test is. Okay, so let's go into, where's my toe? Okay, so toe touch. I don't know why those are out of order. But purpose. So posterior chain, core control, lumbopelvic rhythm. So how the spine and the pelvis move together. What does this reveal about the movement quality, symmetries, potential compensations? So what we're looking for, do they hinge or do they fall over? Do you know what I mean by that? So are we just bending at the waist or are we actually hinging back, touching our toes? Weight shift, are they shifting into one side or the other? Are we having a toe flared out? Are they shifting this way a little bit more? Those are some of the things that we're looking for. Do they have a rib hump? So if they have a right rib hump, what does that mean? Anybody have any guesses? Any of my little intern brains? You have guesses? Yeah. Well, not necessarily higher, but it's shifted this way. If I have a right rib hump, that means that my rib cage is shifted this way and sticks up a little bit more. Does that make sense? So you'll see that in our left AIC people, where they have right rib humps because their rib cage is shifted that way. Feet positioning, we've seen it before, where like weird knee positions where maybe one knee is back, one knee is forward, and you'll see this too in the left AIC positioning as well. And then global picture, is the movement controlled? Do people just fall right over? This also tells us too about hypermobility as well. So this tells us about laxity. You can pretty much tell with this one as well. So let's look. This is our scoliosis friend. Look at how stiff that is and look at his weird rib humps. But that's a reflection of his structural issue. Does that make sense? So I put that in here just to show you that this spine is dictating what we're seeing, right? And all is making sense in the big scheme of things. Overall, he doesn't get any flexion, but that's because he has a rod in his neck. What do you notice about this one? What do you notice? Say it again. More fall over. What else do you notice about this one? Oh. A tiny bit. The main thing I look is that girl just went whoop, dropped right to the ground. She has a lot of range of motion. Whereas like this right here, watch how he slowly like goes into it, partly because of his back, but also that's what some of the things that you'll notice in like hypermobility things. She just like whoop, drops over because she has a ton of range of motion. She kind of blocks her knees out a little bit, whereas he is bent and it's a little bit more stiff to get into some of those positions. So last thing I think on our list to go over today is our neck screening. So this is a cool little chart to kind of lay everything out of what we're looking for. So our neck positioning is also a reflection of our big picture. And sometimes when people come in with crazy neck pain, it might be, or like crazy neck and shoulder. Think about if they're going to throw and they're like doing something weird with their head as they go to throw, that's going to cause some neck soft tissue issues. Or it could be something structural. That's more of like a Tara situation where we're referring out when we feel like it's not within our capabilities. But so let's see. So we're going rotating to the right. Obviously we don't do this middle, but we rotate. Normally what I do is I hold their shoulders so that they have no other compensation movement. We're turning to the left, we're turning to the right, we're looking up at the ceiling, we're looking down at the ground. And this is telling us some of our restrictions. So we're rotating, are we going full range of motion? So that means, are we going chin all the way over? Notice how I have to go out and around to get over. That's a compensation. I can't rotate properly. Is there pain or tightness at the end of these end ranges? And you'll see here, have you guys, when you're filling it out, the cervical movement where it says functional, up here at the top. Functional, non-painful, functional, painful, dysfunctional, non-painful. Does that make sense? So when you go to tab down on there, it's abbreviated. So it's either dysfunctional or it's functional, and it's either painful or it's non-painful. So DM or DN, dysfunctional, non-painful. So maybe that means, like for me, for example, I'm dysfunctional, but I don't have any pain. So that's what that would be for me. Does that make sense to everybody? When they're looking all the way up to the ceiling, we're looking for them to get full. This is a little excessive. This is like a little bit crazy, but this is what we're looking for, where our chin goes all the way up to the ceiling without our mouth opening. So a lot of people can get there, but maybe their mouth is open. That's compensation. Same thing with flexion, where chin all the way to chest without any weird compensations. Let's see what else. Just any of these weird, and EC will get some of these neck ones that are like a little bit weird presentations, but are they getting any weird headaches, nerves, coordination control, any weird stuff with that? You'll see in maybe some of those, but a lot of the times I want you guys to be really proficient in being able to tell guys where to put our active mobility ball in the right places, because sometimes just soft tissue alleviates some of these structural differences. Does that make sense? We have SCM, we have our scalenes, we have our yeah. So think about it. Think about if somebody's tugging on my shirt, right? My pain, or like let's say somebody's tugging on my shirt, and this goes back to our sprained ankle situation. Somebody's tugging on my shirt, and my pain is up here because this is where I feel the pressure, but the tugging is coming from down here. So the issue could be from here, my ankle, but my pain could be felt all the way up here because it's all intertwined, it's all interconnected. Does that make sense to everybody? Cool. Any questions about any of this? Questions? Or things that we want to revisit? Cool? Okay, that's all I have for you today. I know that was a lot of info at once for guys that are just starting, but hopefully you guys also took away something too. So. Cool? Morning. All right, break. Let's pack it. Next week